Andy, tell us about Botox, onabotulinumtoxin type A.
Well, this is a treatment that was found by serendipity. It initially was being used as a cosmetic treatment, and predominantly in women, in their 20s to 60s, which is a very common age to find patients with migraine. And it was found indirectly by William Binder in Beverly Hills, a ear, nose, and throat surgeon, to work very well in preventing migraine in this population in an open label setting. It was not a controlled trial. And he reported on that data in the mid-90s. I was running a headache center and tried using it on some of my more refractory patients using his paradigm. And I was very surprised at the time to find that it actually helped. We were able to reduce things like triptan costs and ER visits. And this gradually led to a much wider use across the community. I know that you started using it around that time, Steve, and we collaborated and worked with Allergan to help them improve the injection technique. It turned out to be key. Where you placed the injections had a big impact on the outcome, and the type of patients that were treated was also important. And it ended up that the patients with more frequent headache did better. And this eventually led to the categorization of chronic migraine. It stemmed in part from the development of Botox through the pivotal trials, which were referred to as the preempt protocol, the preempt trials. And this led to an FDA approval specifically for chronic migraine in 2010.
Still?
I think it's a very important part of our armamentarium, and it's extremely effective in patients with chronic migraine. And over the last decade, it's been transforming for many, many, many patients' lives, many patients' lives. The advent of the new monoclonal antibodies gives patients a choice, patients with chronic migraine a choice. And the question of, as we've already alluded to, whether we leave Onabot in place and then add monoclonal antibodies or subtract, and how payers are going to rule on these issues, those are some of the big battles ahead. But currently in my practice, I try in a very dispassionate way to present both options to patients with chronic migraine and let them choose. And many of them, as we were talking, Deb and I were talking about earlier, will choose Onabot because of its history of utility and safety and effectiveness over the last decade for chronic migraine.
Yep.
I think it also has a lot of really great advantages for patients who have a lot of serious medical problems. And different coexisting conditions that make it very difficult for us to prescribe oral preventives. And that's one of the situations that I definitely encourage people to try onabotulinumtoxin.
One other point I make about it, if we had been smart, we would have realized that Onabot was probably telling us that it is possible to prevent migraine with a peripherally active medication. Because one of the great things about it for our patients is it doesn't go into the brain, and it doesn't cause those kinds of side effects. It's a peripherally active medication. And it predicted, in a sense, what was to happen subsequently, as we think that the monoclonal antibodies, for the most part, don't go into the brain and have primarily peripheral action, which is marvelous from a patient standpoint in terms of side effects.
You know, your previous comment was actually very apropos to what we were just talking about with oral preventives, where we all said in unison, basically, that none of us would stop an oral preventive to start a second one, right? And now we're being asked to do that with Botox and the monoclonal antibodies. And frankly, I think it's sort of cruel and unusual punishment for the patient to take them off something that might be partially effective for them, but not effective enough.
I think there's a way around it. We should actually talk about that when we talk about the antibodies and how we introduce them. Any final comments, Deb?
Yeah, you know, we've talked about a lot of different types of treatments, and this dovetails into something that has really kept me involved in headache medicine. There are lots and lots of reasons to practice in this field, but primarily I'm a neurologist because I'm fascinated with how the brain works. And knowing that all these different medications with such disparate mechanisms of action are starting to unlock the secrets of the brain and what happens during migraine. And it's become more and more fascinating year after year, and I just can't wait to see what's next.